Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Perelman School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Welcome to ModPath Chat. My guest today is Dr. Emad Rakha, professor of breast pathology at the University of Nottingham. He is also a senior consultant at Hamad General Hospital in Qatar, a truly international player. Dr. Rakha is an expert in breast pathology with over 500 peer-reviewed publications. He's contributed several chapters to the WHO Blue Book on breast pathology. We will be discussing his team's recent publication on, believe it or not, still we're struggling with the definition of ER-positive, ER-low. So his paper is on ER-low positive breast cancer. Welcome, Emad, and thank you for accepting my invitation.
It is my pleasure. Very many thanks, Dr. Neto and Dr. Bridget, for this kind invitation to speak about ER-low positive breast carcinoma today. Many thanks.
Wonderful. So let's start with, like I mentioned, I was surprised when I saw the paper that this is still a controversy. So I'm sure there is a reason why you did this wonderful study. So tell me why.
Yes, because as we know, ER was described in the 1960s, and we consider ER as well established for many, many, many years. However, there is still a gray zone between the ER negativity and the ER positivity. And the approach of the oncologist to treat patients with this small cohort of patients showing a low level of ER expression is variable and difficult to manage these patients. So from my point of view as a pathologist, I try to sort out what is the best approach to treat this patient in a consistent way and to achieve the best of patient care.
Excellent. So just for the sake of definition, as it stands according to guideline, how you define, ASCO-CAP guideline, what's considered ER-low at this point for the rest of our audience?
Yes, the ASCO-CAP guidelines define the ER-positive as more equal or more than 1%. And in the updated guidelines, they realized the controversy related to the low expression of ER. So they give this category as a name of low positive. So it is ER low positive. And they advised for further discussion, but they didn't define how can we deal with these cases. And at the same time, my concern is that they consider the 1 to 10%. Oh. And ER positive is more than 10%. So some oncologists will treat 10% as negative or low positive, which can be treated as triple negative or ER negative. Some oncologists will treat them as ER positive. Okay. So it is important to sort out how to deal with these patients. And the 2%, this category is approximately 2% of breast cancer. And as we know, breast cancer like 2.6 million per year. New cases per year. So 2% is a large number of patients.
Excellent. So it's really, I love the approach. So it's really a very important issue. And the question is, 10 and lower, you consider it as a standard. They're keeping it an eye on it as a low positive category. And more than 10 is the positive. And so how did you design the study and what is the cutoffs that you looked at? If you tell us a little bit about the cohort and what technology you used.
Yes. So actually, I just need to introduce this concept of pathologist helping oncologist in treating patients. Because we, as a pathologist, we look at the slides, we know what we are doing, and we give the final results to oncologists for interpretation. So they interpret what we designed, what we developed. So we are in a better position to comment on this and to tell them no, yes, do this, do that, because we have the power of looking, or the privilege of looking at the slides and producing the results. So when I looked at these cases, I collected cohort of patients with ER low positive expression, and I found that some of them, when we repeat, they are negative. Some of them are very weak, which is a bit of tendency towards what we call false positive. But pathologists cannot ignore brown staining of the nuclei. So we have to give a score. And these patients, I said that if a proportion of these patients are genuine ER negative, we need to check before we treat those patients. Are they really ER negative? Are they really ER positive? And if they remain as ER low positive, how to treat them? So the question was multiple question. Is when we deal with this patient in a core biopsy, should we consider them as ER positive or ER negative, or ER specific category, ER low? And this has a lot of implication for treatment management. Okay. Because if we call it ER negative, it may go for genetic screening, for other treatment modalities, immunotherapy, and so on. So the best way to approach for this one is to have more technical input by repeating the staining on the excision specimen, differentiate between false positive and the true positive and the true negative. And then when we reach to a stage where we refine the classification, we can manage the patient based on the actual performance of the tumor.
So you really looked at a large cohort, over 8,000 cases, 8,171 to be accurate. And these, so when you collected the cases, that was based on prior, because you classified them into three groups: ER low, ER positive, and ER negative, right? According to the current ASCO that we just discussed. So these were classified as such, and then you repeated some of the IHC, right?
Yes.
And you also did RNAscope, and you did RT-pCR to confirm whether the IHC is false positive or false negative. And you also classified these lesions according to PAM50 and according to CGA. Is that a fair assessment of what you've done?
As I mentioned, there's a lot of the approach of oncologists is different, so we need to convince them. You don't need to do this in routine practice, but we just to generate data that is convincing for the oncologist. We covered all the aspects that can raise concern. So some of the oncologists may raise concern that on excision specimen, the fixation is suboptimal compared with the core. That's why you lose expression. So ER can convert from positive to negative. That's why we used RT-pCR, we used RNAscope, and we used repeat immunohistochemistry using multiple clones of antibody. So we to know the answer at the same time to avoid any possibility or potential impact of fixation on the specimen.
So when you did all that, what did you find? How many were truly? Yeah.
Yes, we found that approximately 50% of these cases converted to ER negative, or they are actually ER negative, and 50% changed to either ER definitely positive more than 10%, or some of them remained as ER low positive, but a genuine low positive. So for those patients who turn out to be ER negative, they should be treated as ER negative or triple negative breast cancer patient. For those patients who are confirmed as ER positive, this is oncologist approach. They can treat as ER positive. They give hormone therapy because we have ER positive clone. And at the same time, some of the oncologists may see that it is a very low expression, better for the patient to be treated as ER negative. But at the same time, you reduce the discordance to a minimal group. And for those patients, about 20-30% moved to more than 10%, those definitely ER positive. So we reduced the incidence from 2% to less than 0.3%. Of the patient that still need oncologist decision based on the context.
Excellent. And so you mentioned you also did image analysis to see, does the image analysis do better than the pathologist? And And did that really happen, or wasn't better?
Yeah, this is actually again like holistic approach to the issue of image analysis. Image analysis is very, very promising technique for pathologists and for scoring because it is more objective than eyeballing assessment. But we have to be careful that when we struggle, image analysis as well can struggle. So we compared the performance of image analysis in the true positive cases, strong positive, against the cases that is at the borderline, what we call ER low positive. And the performance of image analysis was not better than us as a pathologist. So we three pathologists scored the cases blindly, and we have agreement, the level of agreement, and we scored the strong positive. We have very, very high level of agreement. And then when we applied the image analysis, the concordance was very high in the ER positive, but similar to our performance in the ER low positive. So image analysis is very good option, but not to sort out the area that we are struggling with.
Which is the ER low positive.
Yes. And even in pathology in general, if you have like HER2 low, the issue of HER2 low attracting a lot of attention, we have to be careful when you rely on image analysis. You can rely on picking up HER2 positive. But when we go to HER2 low, you have to be careful that image analysis is not better than us in interpreting these low expressor cases.
The question is, who are us? So if you're talking about expert breast pathologists, like I'm sure the group that did this study, it's the experience matters. So one can see that a role for image analysis for pathologists who don't, the same thing in prostate cancer, pathologists who are not subspecialized. So the importance there, whether it's general pathologists or subspecialized. But as it stands, subspecialized pathologists still as good as AI, which is which is good to know. Now, I want to clarify. So in the study, what you considered low positive is the 1 to 9%, right? Between
yes.
1 up to 9%. And you mentioned something about the 10%, and that could be a potential change for the new range of positivity. What about the 10%? Exactly 10.
Yeah, we hypothesized at the beginning that 10% should be different from 1 to 9% because the ASCO-CAP guidelines state that 1 to 10 and more than 10 will be positive. So I had a concern that 10% should be 1 to 9 and the 10 or more should be one category as positive. So we recognize ER low positive, but it is 10% is a bit more. So 10%. So we tested 10% on its own. We found that tumor with 10% behave exactly the same like ER positive. So there was no difference between 10% and 11 to 30 or 11 to 40. While 10% was different from 1 to 9. And 1 to 9 was different from negative and different from 10%. So we provided evidence that tumor with 10% should be considered as ER positive tumor. And as you know, pathologists tend to round up when we saw cases, so we need to make it 5%, 10%, more than 7, or even 7, but not 8 or 9. So 10%, we found that a bit of peak incidence or increased number of cases at around the 10%. So we don't need to consider these cases as low positive. They are true positive when you have 10%. And we confirmed this by repeating the staining, by looking at the molecular profile, by looking at all aspects. They showed evidence that they are similar to ER positive. So hopefully next ASCO-CAP guidelines will rechange the definition of ER low positive to 1 to 9, and the 10% or more will be considered as true positive for management purpose. And I am hoping that they will also look at the technical aspect of the process, not only the oncological aspect and how to treat patient, but how to reach to the right diagnosis. So there should be like a mandatory documentation or a recommendation to test these cases on the excision specimen or repeat biopsy or do extra step to make sure that are we dealing with ER positive or ER negative patient for further management. As you know, ER positive patient will receive hormone therapy for 10 years. It's not something easy, not something you take it lightly. And If it is ER negative, they should take different regimen of chemotherapy and different treatment modalities. So it is an important decision for a subgroup of our patient.
Emad, really impressive. How simple from on one hand, and how important on the other hand, and technically savvy you approach this. So I congratulate you on the team, and hopefully you'll be able to convince the ASCO group. I think the CAP group will be easier to convince, but it's always evolving guidelines. And you mentioned we need to have you to talk about HER2-low one other time. So, but hopefully what's going to happen is the one between 1-9, these should be either you reflex to another method like RNAscope or RT-pCR, and or repeated, like you said, on the excision, because the needle seems to, especially in that group, seems to be not very informative and can change, and hopefully move the guideline toward including 10% with the high. Once you achieve that, we'll have you back to discuss, and maybe what's the next study you do to prove that this really matters, because the proof is always in the outcome and following the treatment with the new guidelines. So thank you very much for submitting so many studies, excellent studies to modern pathology, and thank you for being on this episode. I'm sure our audience appreciated and learned a lot.
It is my pleasure to be with you. Thank you very much.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.